Welcome to Think Like a Nurse, the video outreach of KeithRN.com. Today's topic is the solution of how we can as educators transform nursing education and preparing our students to think like a nurse so they don't harm their patients in clinical practice. The solution, according to Dr. Patricia Benner and her co-authors in Educating Nurses, is this. Number one, we must contextualize our theory content to the bedside. Remember, as I discussed in our last topic, problem that Dr. Benner and her co-authors identified in nursing education that must be changed is the classroom. And so that's where my emphasis is for this topic as well. So we must contextualize our theory content and apply it to have relevance to the bedside where the nurse takes care of the patient. We must shift from a focus on covering decontextualized knowledge to an emphasis on teaching for a sense of salience, nurse thinking and action in whatever that situation requires. This again can be practically done through clinically derived case studies that situate the clinical realities in the safety of the classroom. Students are asked to identify what clinical data is important or relevant and why. So we present the knowledge of lab values, but students must identify which labs are abnormal and which ones must be acted upon just as they do in clinical practice. My definition of critical thinking is recognize the relationships between clinical sets of data. For example, if your patient was just admitted with heart failure and an exacerbation, has an ejection fraction of 20%, their creatinine is elevated and have an elevated BNP, they have a chief complaint of shortness of breath and have crackles halfway up their lung fields, what are the clinical relationships and the physiologic rationale for these findings? These relationships and the physiologic rationale must be understood by the student nurse. And this needed learning can be situated and practiced in the classroom to prepare students to identify these same relationships in the clinical setting. And the fundamental reasoning activity that I've developed really does an intentionalization of this concept of Dr. Patricia Benner from Educating Nurses. Number two, how we can be the solution. We as educators must provide opportunities to practice clinical thinking and reasoning by using clinical imagination in the classroom. Isabel Hampton Robb, the most influential American nurse educator of the early modern era, also recognized the value of practicing any needed skill. She writes in her book, Nursing Ethics in 1900, this: only by constant repetition can you become really familiar with the work. Only by doing a thing well again and again can you obtain the confidence, accuracy, and precision. It is this constant, intelligent practice that constitutes the difference between the skilled, trained professional and the amateur. Despite the common use of the term, born nurse does not exist. It will always be necessary to take hold of each task and do it over and over again, being guided by an intelligent, trained mind, which is us, the nursing educators that our students work with. We must recognize that thinking is a skill that must also be practiced to become proficient. For example, Foley catheterization and other clinical skills require this repetition, and we give opportunities to do this in the skills lab, but the classroom must also become this lab environment to practice nurse thinking with clinically derived case studies. Clinical imagination as defined by Dr. Benner, is this: nursing students need to acquire knowledge in a way that relates directly to the skilled know-how they are developing in clinical situations, and to acquire knowledge in a way that allows them to imagine the situation and rehearse or practice for them. She's saying just what Isabel Hampton Robb said over 100 years ago. Clinical reasoning case studies, again, is one way to make this possible and give our students the chance to practice. Clinical imagination also conjures up possibilities of what could happen in this situation and be prepared for the worst possible problem. The what-if questions are an effective pedagogy in the classroom and is the clinical to develop this needed nurse thinking skill so that nurses are anticipating versus reacting to a patient problem when it develops. So for example, if your patient is at risk for sepsis, what if their temperature is 101.5 and their systolic blood pressure is now 85 when it was 120 4 hours ago? What if? What if? What if? The third point that we must do to be the change and to really change the paradigm in nursing education is this: we must whittle away content and emphasize concepts in our lecture presentations. Now, concepts are content, just the most important. Use your experiential knowledge as a nurse and draw from your team as needed, and look at your existing PowerPoint presentations and make it a goal to whittle away 40 to 50% of what is on your PowerPoint presentations and emphasize salient concepts. Then use the remaining time to situate these concepts with a clinically derived case study and apply their knowledge and give your students the chance to practice their thinking in addition to their knowledge. The final point that Dr. Benner says we can do to be the solution is emphasize clinical reasoning as a systematic approach that reflects how nurses think in practice. Now, critical thinking has long been the emphasis in nursing education. We want our students to critically think, but it's inadequate to capture needed priority setting and action when a patient has a change in status. NANDA, nursing diagnostic language, is unable to capture the essence of needed priority setting when a status change occurs. And I'll have another topic on this very essence of NANDA versus clinical reasoning on another day.